So, good afternoon. I think more people are walking in, but we'll go ahead and start the session in the interest of time. What? Oh. Okay, here. Where's the mouse? So we'll start the session in the interest of time. I want to first of all thank the organizers for putting this session together, for the invitation to both myself and Peter Netlin. As I mentioned earlier today, Peter has been my source of inspiration and the reason why I went into glaucoma. And we thought what we'll do is to take glaucoma, not the open-angle glaucoma, but the complex glaucomas that we face in our practices, and we're going to present 6 minutes each one of those topics, and we'll have an interactive session with the audience. I want you to give us a feedback. This is how we practice in our own practices. I'm not telling you anything that we read and have not practiced. Everything that I'm going to show is my practice, my patients. This is how these patients are being treated, and they're all successful. And the same with Peter too. And it could be that some of the techniques that we're using are not being used in India at this point in time. And so I'm hoping that I'm going to learn from you guys, and you guys are going to learn from us, and put together, patients will benefit at the end of the day. Okay? I showed this in the morning. I'll repeat this because it's one of the topics that I was given, angle closure glaucoma. Acute angle closure glaucoma, as we all know, this is a six-minute capsule, okay? So I'm not going to go into the details of a lot of these pathophysiologies, etc. We're going to show you a case situation. We're going to show you how we treat this. Small eyes, large lens, shallow chambers, narrow angles, pupillary block mechanism, iris bombay, angle closure, and then the patient typically presents to you with a red hot eye, steamy cornea, decreased vision, nausea, vomiting that could be going on for days on end before the patient finds a surgeon who is willing to take on the patient, right? Standard of care, IV mannitol, oral acetazolamide, topical pilocarpine, topical aqueous suppressants, and a YAG-PI when the cornea clears up, and hopefully the attack resolves. The attack may not resolve if the attack has been going on for longer than 3 or 4 days or 5 days. If a chance is given for the cynical adhesions to form, even a YAG-PI cannot resolve those attacks, right? And then, of course, the YAG-PI in the fellow eye, don't forget, it's a bilateral disease process, even though the patient can present to you with only one eye. So what do I do in these cases is I showed this in the morning too, here is a 45-year-old oil trader presented to me with count fingers vision, pressures of 72. His cousin happens to be a comprehensive ophthalmologist. He's a +13 hyperope. She dilated for a routine fundus examination, put him into this angle closure attack for 4 days. They tried everything, including IV mannitol, Diamox, all the drops. He kept on throwing right through the night before the patient ended up on my desk. And what do I do is what I'm showing here. It's pretty simple. It's not that radical as you think it is. A lot of people made this comment that this is radical. It is not. In fact, if the aim of the treatment is to resolve the issue immediately, which is, for the patient's point of view, it's severe pain, nausea, vomiting, this is the best technique that you got. No drugs needed. Put the patient at the slit lamp, a little bit of betadine, a little bit of tetracaine drops, and then use a 30-gauge needle with the hub away from the syringe, and then use the 30-gauge needle to enter the anterior chamber, and miraculously, within 2 minutes, a few drops of aqueous will come out, and the pressure goes down, pain is gone, the cornea clears up. Now the patient is a believer in you, okay? Pain is gone. And so you take this patient now and perform the next step, which is laser rhinoplasty. You do a 0.3 milliwatts of a laser or 300 micron spot size, 300 milliseconds time duration for 30 spots. And I don't even use a lens. So you just go around 360 degrees. It will shrink the iris, peel it away from the angle structures. A combination of reducing the pressure, doing the rhinoplasty pretty much resolves the attack for you. And once this is done, I put the patient on steroid drops and antibiotic drops and a combination of glaucoma medications plus or minus Diamox as the case might be, and wait it out till the patient, the eye quietens down. And then one final stroke, what I want to do is to make sure that I cure this condition. And the way to cure this, in my mind, is to put the anatomy back where it belongs, i.e. take that damn lens out. Once the lens is taken out, there is enough room in the anterior chamber. Once the chamber is deep, the angle is open, this patient is never going to have another attack of glaucoma. Now, one can argue that this is a radical approach, but I can tell you this is the only kind of glaucoma that I can confidently tell the patient, you're cured. You don't need to follow me anymore. Okay? And why not take that opportunity to cure this kind of glaucoma is the way I look at life. You can argue that here I'm doing goniosyncytialysis a couple of different ways. You can use a viscodissection using the viscoelastic injection in there and the cannula up and down, anterior-posterior motion. Or you can actually use the IA tip to grab the iris gently and peel it in, towards the center and peel the iris adhesions from the angle, and that will also achieve the same target. Once that's done, you know, I do the stepwise approach, and I had great results. And always remember to treat the other eye. The other eye is equally at risk. Do what it takes. A YAG PI is all that takes. That's perfectly okay. In spite of a YAG PI rhinoplasty, if the angle continues to be narrow when you monitor it, take the lens out. I mean, we are all expert cataract surgeons. The risk is very minimal in the present day. Do not hesitate. At least I do not hesitate. Now I'll turn over to Peter for his comments on this, and then talk on chronic angle closure glaucoma.
Yeah, great comments. We can turn it up a little bit on me, I guess. There you go. Thank you. Great comments. Don't have much to add. Obviously, the conventional treatments are the way to go if you can break the attack easily with osmotic drugs and Diamox and pilocarpine, and medically you can break the attack easily. Great. If you can perform a laser, makes a lot of sense to do that if the cornea is clear. But there are some situations when when doing a paracentesis, can be useful. It's a bit counterintuitive, but it can make a lot of sense. In certain some clinical situations, it may be the best option. So that's the only comment I would make, is that sure, we have other treatments. They make more sense in some ways in terms of the pathophysiology of it, but it certainly does work. There's quite a bit of literature now that explores that option, and it's something that you can do. Obviously, you want to get to a more definitive treatment for the problem afterwards. If it's doing a laser, that's fine. If it's doing a lensectomy, that's fine. But some way to make a more permanent treatment. But it certainly can be very, very helpful to break the attack. So I'm going to talk about chronic angle closure glaucoma management for just a few minutes, and we're talking about chronic angle closures. It's categorized based on the duration of angle closure. So we're talking about something that's not just subacute; it can be broken and then reversed easily. We're talking about months to weeks to months to years. We're talking about synechial angle closure, generally speaking, with this. And it's really interesting when you look at how much angle you have to close to actually cause chronic angle closure glaucoma. We're not generally talking about a few small PAS. We're talking about broad areas of the angle that are closed. And this dates way back to Dr. Morton Grant's original studies on this, which were done, I think, in the 1960s or 70s, where he looked at how much angle you'd have to close to get an increased intraocular pressure. And with a normal person, you really have to close about 3/4 of the angle to see the pressure rise. With an abnormal person, somebody who has reduced outflow facility, you may only need to have about half the angle closed. But still, that's a very substantial area that you have to close to see really a chronic rise of the pressure. So there's obviously many things that channel into chronic angle closure. We're talking about all of those things, generally speaking here. But it's a really multiple mechanisms, and there's multiple pathways to get to this point. But we're talking about the end state, the end point for many of these different approaches or conditions. Nowadays, we do have anterior segment OCT, which can be useful if you can't visualize the anterior segment very well. This is back in the day, me doing capigonioscopy before I had gray hair, And then now here's the more modern Visante. This is a person with chronic angle closure glaucoma. You can see this part of the angle is open, but this part has synechial angle closure. And this is a person that had a fairly opaque cornea. So it's actually very nice to be able to use some of these techniques if you have to in some patients. We're looking for, in these patients, some of the chronic sequelae to help with the diagnosis sometimes. Glaucoma flecken are sort of interesting. We talk about them a lot, but they're very unique to angle closure glaucoma. It's actually, to my knowledge, never been described in any other condition. So they are pathognomonic, it seems, for angle closure glaucoma. If anybody has seen a different condition where they've seen actual glaucoma flecken, let me know. But for some reason, this is very unique to this. And you know, that's the long-term sequela. So medical therapy, usually you can start off the standard approach is to start off with aqueous suppressants, beta blockers, carbonic anhydrase inhibitors, and you can use prostaglandins. There's been a few papers published about long-term use of prostaglandins in chronic angle closure glaucoma patients, and there can be a benefit, almost as much as in open angle patients for some strange reason. So you can have that as an option for the long-term treatment. And then, of course, in the short term, if they have a marked elevation of intraocular pressure, it's much like with acute angle closure, we can treat with osmotic drugs. My favorite is glycerin. It's great. You can give it PO. It's fairly safe. Carbonic anhydrase inhibitors, you can do any of those things. Now, laser procedures, we're not going to talk about laser iridotomy because that's mainly for acute angle closure. I'm going to assume that pupillary block component has been removed in these patients for the most part. So if you do treat the pupillary block somehow, usually with iridotomy, then you do have some other laser options if the angle remains closed. You can do a iridoplasty, a gonioiridoplasty, or a goniosynechiolisis. So a laser iridoplasty and gonioiridoplasty is pretty simple. It's used for all of these different conditions, including angle closure that's unresponsive to an LI. Presumably in this case, you're thinking that it's not synechially closed yet. You're going to reverse it with this procedure, but we'll get back to this in a minute. You can use this in some procedures where there's actual synechia in some patients. So iridoplasty and gonioiridoplasty are basically, with an iridoplasty, you treat the outer quarter of the iris. You can treat it without a lens. Just you're putting in about 8 to 10 spots per quadrant. Relatively light treatment. Your biological endpoint is shrinkage of the iris to see if you have the effect that you want. Gonioiridoplasty is using the gonio lens to put in the spots. So you're using a smaller spot size. You can't see the bigger spot sizes in the gonio lens. So your maximum is about 200 to 300 microns. And then the usual settings are like 600 or so milliwatts and 0.1 seconds or so. And then you should again see shrinkage in the angle where you're treating these spots. You can put in more spots in the gonioiridoplasty than you can in the straight iridoplasty. The concern on iridoplasty is if you put too many spots, you might see damage to the iris vessels and ischemia and a large pupil after this if you don't lighten up the treatment, if you do too heavy of a treatment. So goniosynechiolisis is the same thing as a gonioiridoplasty, but it just has we just call it a goniosynechiolisis if you actually break synechia by doing this. So your purpose is to stretch the iris and then to see the synechia break under direct visualization. This was published many years ago by Martin Wand initially. Now there's been many papers about this. It's thought to be useful up to, if you know the time course of how long the angle's been closed, it's thought to be useful up to at least 2 years. In the original papers, they had patients that had as long as 2 years of angle closure and then were reversed by doing this. But it's unknown if it's thought that if you have a long time of angle closure, then probably you can't reverse the permanent damage. But if you catch this within a couple of years, you can usually improve the situation with this if you can open the angle. This patient was a great candidate for synechiolisis because she had angle closure after a scleral buckle. And so this is something that does spontaneously improve after time. They may loosen the buckle or it may just spontaneously improve. But she had angle closure and she had synechial angle closure. So do you want to just leave that completely closed forever? Or now that her choroid is not swollen, do you want to try to reverse this with a laser that takes 10 minutes and then have it permanently cured? So that's what we chose to do, and it was a great result for her because no medicines, no glaucoma surgery. but she had a condition that was going to spontaneously improve over time. If you have a cataract, it's the same thing. Your thought is you're going to reverse the problem that's causing the angle closure. So you can do this kind of procedure because you think, well, I'm going to break the synechia, and then I'm going to eliminate the cause of the iris being pushed forward or whatever, and then you're going to have a permanent cure. That's the thinking that you have. Similarly, if you have a patient that has phacomorphic, they have a pupillary block component, there is many papers showing there's a small benefit of iridotomy in that situation, but obviously it's not going to permanently control it. So you can then do a cataract surgery followed by surgical goniosynechiolysis as well. That's a very logical, stepwise thing. If you do the cataract surgery, check intraoperatively with your gonio lens, and you still have an angle that's closed with synechia, well, it's relatively recent. Why wouldn't you want to reverse that? So you can do surgical goniosynechiolysis. It's well described for at least 30 years, 40 years. Very popular method now uses vitreous forceps. The old technique was we used to hyper deepen with viscoelastic and then push the iris down a little bit. Now the more modern technique is we use vitreous forceps to put radial traction on the iris and break the synechia that way, preferably under direct visualization. It's very easy to do this, and it can reverse and eliminate the glaucoma in somebody you've done cataract surgery on, and so this is very popular in many patients now. Patient care in many patients. Surgical treatment, obviously we can do trabeculectomy with monomycin C, drainage implants, and even MIGS now for people that have chronic angle closure. And so many of the young glaucoma people and our fellows pretty much always prefer to do MIGS in this situation. So Asian patients, we went through this morning, and not us, but the previous session, and I think the concept of doing cataract surgery, goniosynechiolysis, and even trabeculectomy in some situations can have a role in chronic angle closure. So the idea is to try to prevent the angle closure or do early reversal. That's the ideal because then you've got a permanent cure. You can diagnose it with even anterior segment OCT now, and laser and surgical goniosynechiolysis are useful in a small portion of patients, especially when you know that you've reversed the problem that's causing the angle closure. And then certainly if you have just a persistent chronic angle closure situation, you can do medical therapy or even surgical therapy for those. So that's a little summary of angle closure. And any comments?
So MIGS, in my practice, is playing an increasing role in the management of this chronic angle closure glaucoma. I was mentioning this to Ramanjit in the morning. You do goniosynechiolysis in these patients and then strip the trabecular meshwork, open the canal into the AC. I'm finding that these patients are having long-term good intraocular pressure control. It's a very simple technique. I use the KDB blade. I use goniosynechiolysis like you described with the microforceps, and then combine that with stripping the trabecular meshwork, open the canal into the AC, take the cataract out, reform the chamber. And in my practice, my experience, we have more than 1 year follow-up on some of these patients. They're doing great.
Well, that's been the debate for a long time. So have you seen some patients that have had more than a couple years of angle closure? Because the theory is that if you then remove the juxtacanalic down to the juxtacanalic meshwork, you can cure those too. So if you had some longer term, you think, angle closures that... So
the reason why I cannot answer that question honestly is a lot of these patients are misdiagnosed as chronic angle closure glaucomas were mistreated as open angle glaucoma by the primary referral doctors. Okay?
So you don't know how
long. We don't know how long this angle has been closed. A lot of times what I find is the pigmentation that was shown in the morning that gets deposited in the anterior portion of the meshwork and some of the cornea, the junction, is mistaken to be the trabecular meshwork, when in fact the angle is 360 degrees closed. And so that is something that people have to practice gonioscopy. Unless you know what is normal, you will never know what is abnormal.
Yes, and we can stop for questions too. I'm sorry. Yeah, go ahead. Yeah, thank you. Yes.
I think for the last 10 years, we've done a lot of histopath studies, both light microscopy, electron microscopy, transverse electron microscopy, and scanning electron microscopy. If you were to see the trabecular meshwork in a chronic angle closure glaucoma patient, there are no spaces. It's just fused trabecular beams and no endothelial cells whatsoever. You look at a scanning electron microscope and there is like a flat surface that you see. So I think that, things like goniosynechrolysis and whatever do work in very early cases. As you were saying, acute angle closure comes to you within a day, 2 days. It's a possibility before the fibrosis and these fusion of the trabecular beams have taken place. But I think once you have pressures, and I say this, and I think everybody here will agree, that chronic ACGs that we see are 30 plus. Their intraocular pressures are 30 plus. So if we think that, a lens extraction and a goniosynechrolysis is going to take care of that 30 plus in an advanced glaucoma and bring it down to 10 and 12, it doesn't happen. So I think we have to choose our patients depending on the amount of damage to the optic nerve, the duration of the attack of the angle closure, and be aware that when they come to you with 40 plus pressures that have been there for a few months or a few years, that there is no trabecular meshwork that is functioning. You have to give it an alternative path for the aqueous to go out.
Yeah, it's a great point, and that's interesting because in the studies that have been published, Martin Wan's original study and then all the subsequent ones, they've used this 2-year time point as the threshold, where beyond that you're going to have some permanent damage, like I say, compression of the meshwork and stuff, and that's why I'm so fascinated to hear this comment because. Now we have some of the new MIGS techniques, and we'll touch on these a little later. You're actually, with a KDB blade, for example, you're actually excising the entire trabecular meshwork down to Schlemm's canal, removing all of it. So you have the theoretical potential. That's why I'm kind of fascinated by that comment, because you've got the theoretical potential to then remove that and then sort of normalize it. But I mean, I agree with you. I think there's that point at which it's kind of really more or less irreversible, or certainly you're going to have some at least reduction of outflow facility, certainly. But I still have that optimism that with these now new tools to remove the meshwork, if that's the site where the maximal obstruction is going to be, that maybe we can have some long-term results with those patients too.
Ramanjit, I'll present to you a simple case. I had a patient not too long ago.
I'm agreeing with you. I'm just saying that in Caucasians.
No, I agree completely with what you said. Okay, but I had a patient not too long ago, African-American lady, came in with pressures of 50 on 4 drops or whatever maximum medications, a damaged optic nerve. I took her chronic angle closure glaucoma. I took the lens out. I did a goniosynechrolysis. I did a KDB to open the meshwork 180 degrees, open up the Schlemm's canal. I combined that with ECP to decrease aqueous production. Now you have a pathway that you created for the aqueous to get out through the Schlemm's canal, and you decrease the aqueous production. Combination of both with COSAPT, which is dorazolamide timolol combination, reduce the pressure down to 15. Okay, I am seeing, I was just like what you said in the past, if the angle is shut, it's not going to be functional. The canal is still functional in these cases. That I can swear, because I'm seeing that in my own practice. In the next couple of years, I'll gather the data as I get, I never believe in publishing a glaucoma paper on any surgery related to glaucoma with the 3-month follow-up or 6-month follow-up. As we all know, at the end of 1 year, at the end of 3 years, at the end of 5 years is when you know whether our surgical techniques are working or not. So I'm still waiting for majority of my patients to reach at least a 1-year mark before I publish on this. But the trend that I'm seeing is really impressive. Now, there are some patients who need the trabeculectomy.
It's a combination.
It's a combination.
You're doing an
yes.
endocyclophotocoagulation, you're doing the goniosynechrolysis, you're using the KD blade. There are multiple things that are happening, and probably out of these, something will work. So we're not sure which of the 3 are working, and which is actually sort of producing the
okay, so I actually have a paper that I'm presenting as soon as I go back in the American Glaucoma Society, looking at goniosynechrolysis alone versus goniosynechrolysis with KDB and ECP in patients with the plateau iris syndrome. I actually have a paper that's come, and we will write the paper up, and I will send it to you before I publish it to get your impressions on it. These are changing concepts in glaucoma. Some of the things that we thought were not possible are becoming possible now. Without, if we can avoid having trabeculectomy, as much as I love doing trabeculectomy, I don't like to have it in my own eye. Let me put it this way, okay? Because I've seen too many people waking up blind. When you're talking about waking up blind, they literally go to bed with 20/20 vision. Next day morning, they're NLP, because that blood-related endophthalmitis is something severe more complex, more complicated than the endophthalmitis that follows simple cataract surgery. You agree? So.
Yeah. Well, and to keep it in perspective, you know, it's a good point. You know, to keep it in perspective, yeah, the procedures, if you combine multiple MIGs, sometimes, like a KDB, for me it takes 5 minutes, right? And how about for you? 5 minutes?
Yeah, less than.
And then ECP, I don't do as much, but that's maybe 10 minutes or?
No. I mean, the KDB literally is a 3-minute procedure. ECP adds you another 5 minutes. So you take your cataract out. I'm not exaggerating when I tell you this. I can show you live videos, or anyone wants to come and observe me, you're all welcome to see. On a good day, my cataract surgery takes me 3 minutes. On a bad day, it takes me 6 minutes, and you add another 4 to 5 minutes. In 12 minutes time, I'm done with this entire procedure. All the 3 procedures that I'm talking about, I'm done, and the patient is benefiting from it. I am seeing it in my own practice. So I urge you to consider at least these kind of techniques to see in your own practice if it's going to work. I guarantee you some of them are not going to work, in which case I will take them back and do a trabeculectomy operation. There's no question about it. But these things are working, even in patients with advanced glaucoma, because in the beginning stages when MIGS came out, the concept was it's only for mild glaucoma. But I am more and more using MIGS in combination with other advanced glaucoma techniques, and I'm finding good results. For example, if a patient had TRAB and the TRAB is failing and the patient is back on 3 drops, now has come back with cataract. While you're doing a cataract surgery, you combine that with MIGS, I'm able to eliminate almost all of the drops, or at least 2 of those drops, and leave the patient only on 1 drop and restore the vision and control the pressure at the same time. And you also eliminate the post-op pressure spike that is commonly seen in these glaucoma patients, as you all know. So let's move on to the next topic, which is complex cataracts and glaucoma. Special issues with cataracts and glaucoma patients: small pupils, fixed and dilated pupil, uveitis, trauma, hyphema, whatever the background is for the glaucoma, low pressures, high pressures, shallow chambers, angle closure, floppy iris, and rarely snuff-out phenomena that you see that you can potentially encounter doing this. As glaucoma specialist, I don't think there is no other surgeon in ophthalmology who is more used to doing small pupil cataract surgeries. We do it on a daily basis, and we've been doing it for a long time. And I can tell you I've never used a Millennium ring or any of the rings. I always depend upon these reusable capsular hooks, and I stretch the pupil to the point that I want, 6 millimeters or so. You don't want to stretch it too much, especially this particular case as iris atrophy. If you stretch it too much, it's going to cause a tear in the iris, and you end up with a messy iris situation. Even then, this patient with primary iris atrophy ended up with a distorted iris that I had to do after cataract extraction, recreate her pupil. So as a glaucoma surgeon, the reason why I'm showing you this is you got to be you got to develop the techniques for you to recreate the anterior chamber. You cannot walk away saying this is not glaucoma, so I'm not going to deal with this. When you enter the anterior chamber, you want to leave the anterior chamber back to what it was that you found, as close to it as possible. You know, this patient ended up from 2200 vision with pressures of 30. What I did not show is gonial synecholysis that I performed on her with pressures 15 with 2 drops, and her vision is improved to 20/30, and she's extremely happy. I did both her eyes back to back. There's pupiloplasty. In some degree, the pupil that was completely irregular, now there's a sufficient pupil now that you can actually examine the retina and the fundus. Let's go to another patient with a bound-down pupil with chronic angle closure glaucoma, which seems to be the hot topic of the day. And here is how I deal with them. You see this? That's a viscoelastic cannula. You go in through the paracentesis, you break those adhesions. Once you break those adhesions under viscoelastic coverage, you can inject preservative-free lidocaine and epinephrine. That will stretch it even more. If you're not happy with that amount of dilation, then go with your collar buttons. And these are reusable. You can use it for as many patients as you want. It's not going to cost you any more than the initial investment of whatever $50 that you spent on those hooks. And you stretch it only to the point that you're comfortable taking the cataract out. I mean, generally speaking, 6-7 millimeters is plenty for us. And once you do that, you take the cataract out. Let me fast forward this, and here I am. I'm combining that with the Kahoot blade. Now, one thing that is impressive with the Kahoot blade is I can do goniosyncytial with the Kahoot blade using the anterior-posterior approach, breaking those adhesions, and sometimes it bleeds. Even if it bleeds, it's never going to be a chronic long-term bleed. You can wash it out, and the patients do very well. To get 180 degrees or as close to 180 degrees, you want to reverse the Kahoot blade in the supranasal quadrant and the infratemporal quadrant and join the two together, and it opens up the angle nicely. Nano-ophthalmos, there is no need for sclerotomy anymore, in my opinion, if you know your cataract surgery. Experienced cataract surgeons, back in the day when sclerotomy was described, I believe. Can you shut the door, please? Back in the day when sclerotomy was described for nano-ophthalmos, it was in the day of intracapsular extractions and extracapsular extractions where you used to make 8mm incision and getting the entire thing out, the inner contents of the house out. Because of the thick sclera, these patients develop spontaneous uvular effusions, and all the contents of the eye could expel spontaneously. But in this era of 2mm cataract surgeries, you really don't need to do sclerotomy. The area that I live in and practice, we have this Cajun population which has a high degree of consanguinity. They keep marrying among themselves, and I get to see a lot of angle closure glaucomas, a lot of plateau iris syndromes, quite a few nano-ophthalmic eyes that I've taken care of over the years. And one other thing about nano-ophthalmos, you don't need to aim for perfection. This lady needed a 45 diopter lens if I have to make her emmetropic. First of all, they're amblyopic to begin with. You can never get 20/20 vision in them. Two, by the time they come to you, they are wearing such thick glasses, okay? I left her with a 32 or 34, whatever the highest power that Alcon was providing. I used that lens for them, and that lady ended up wearing a 6 diopter thinner lens on top of it. Her vision improved from 2200 to 2060 range, and her pressure dropped down from 30 on 4 drops to 15. I just saw her like 2 weeks ago. I've been watching her for the last 8-10 years now on 2 drops. She's happy, I'm happy. So don't aim for perfection. Here is another kind of situation that causes glaucoma, capsular bag subluxation and Oct syndrome. More and more, as we operate on these exfoliative glaucomas, and you take these cataracts out over a period of time, they're coming back nowadays. I don't know, Peter, you're seeing this in your practice too. They're all coming back now 10 years after the cataract surgery with the subluxated intraocular lenses within the capsular bag. Back in the day, we used to take the entire capsular bag intraocular lens complex out through a 6, 7, 8mm incision, and then suture in a lens. What I've been doing for the last 3-4 years now is to capture the haptic within the bag and hang it to the iris using the mechanical suture. It's pretty easy. It is not that difficult for you to do this. And once the haptic is inside the capsular bag, you don't have the rubbing and pigment dispersion. So it's a great technique for you to remember. You do the same thing on both sides, and it's not a difficult procedure to do. So in summary, cataracts in glaucoma patients are challenging and complex. You have to know how to deal with small pupils, subluxations, shallow chambers, angle closure, high pressures, low pressures, whatever is thrown at you, you got to be able to take care of these patients. So all glaucoma surgeons, in my opinion, need to become technically competent to take care of all these complex issues to benefit your patients. Thank you.
Yeah, just to comment on the nanophthalmos, I've had a run of nanophthalmos patients lately for some reason, quite a few of them, and I've been doing, I did some posterior sclerotomies on a few cases. I've been doing less of them. I haven't done probably in the last 5 cases or so sclerotomies, and I haven't had any problems. Now, the problem with sclerotomies, though, is that you're preventing that disastrous complication that can occur with the intraoperative choroidal effusions, which can be very severe and very dangerous, and they can be very rapid. So I don't know if it totally prevents, I don't know if we'll have 0 rate of intraoperative choroidal effusions, but I agree with you that it is, with modern cataract surgery, it seems to be relatively safe to do it. In the era of intracapsular surgery, when of course we had to do the sclerotomies, then it was really high risk because you had periods of hypotony that were rather, longer. With phaco surgery, modern phaco surgery, you really don't have such long periods of hypotony, and perhaps it seems to be safer. So yes, I would agree that I think you don't, it's not mandatory to do, sclerotomies at this point, but, it's just something to keep in mind, though. It's a good trick to have, because if you have a patient that has really high risk for whatever reason, then it may not be a bad idea to use it in some cases. But I agree that it's not needed in every case now. So I was going to talk about silicone oil and glaucoma just for a few moments. Patients that have long-term silicone oil endotamponade have an increased risk for glaucoma. Many of the regular procedures that we use may not be as effective for glaucoma associated with silicone oil. So this has been a topic that I've been interested in for a long time. We've had many improvements in silicone oil, and we've had many improvements in how we treat it. So I'm not even going to talk about doing inferior iridectomies, because that's now a standard of care. If you have long-term silicone endotamponade, hopefully your retina surgeon has put in an inferior iridectomy, because that's now considered to be standard of care. So I'm going to assume that they've done that. The other thing is that all worldwide, we've had a complete change in the silicone oil. We used to use much lower centistokes silicone oil. Now the standard is 5,000 centistokes. But more importantly, they've become much more highly purified over time. The older emulsions were not as pure, and so they would emulsify much more easily. Nowadays, we're seeing much less commonly that kind of creamy emulsification that used to occur frequently, and that's mainly because of the improvements in purification of silicone oil. So at any rate, we still have the same risk factors for glaucoma, pre-existing glaucoma, aphakia, steroids, but and many of the standard approaches, cyclophotocoagulation has had a very poor outcome in these patients, generally speaking. Trabeculectomy can be done, but the problem is the oil floats, and so that's not a good situation for long-term endotamponade. And you can improve the situation by asking the retina surgeon whether they can remove the oil. Many times they can after a year, but sometimes they can't. So we've looked at a lot of patients with this. So this was a series that I was involved with, where we monitored 450 eyes with long-term silicone endotamponade. And actually only about 11% of those developed increased intraocular pressure over time. And initial medical therapy was effective in controlling the majority of those, about 78%. The types of glaucoma are kind of interesting to me. It's actually not just related to silicone oil directly. There's many different causes for the increased intraocular pressure, and they're listed here, but you still can see a certain percentage, small percentage, that you can only attribute to the silicone oil. You see droplets in the anterior chamber, an emulsification, superiorly on gonioscopy or something like that. If there's any oil that's in the meshwork, then we assume that it's mainly due to the silicone oil. But at any rate, relatively small proportion. This is the pressure curve over time. Not really huge elevations, mainly treated with medical therapy, but a small percentage of these, about in this case, this is only 51 eyes out of 500 that developed increased intraocular pressure. But if you look at these patients, a small percentage of these will need glaucoma surgery. So this was a series of 94 eyes and 94 patients that required surgery for silicone oil-associated glaucoma that was with mainly long-term endotamponade. And in these patients, we treated them mainly with drainage implants, which were put in the inferior quadrant. The issue with trabeculectomy in the inferior quadrant is that it has a higher risk, and so we try to avoid the inferior quadrants for long-term complications. So drainage implants don't have that issue, so we put them in the inferior quadrants. And you can see that pressure control was actually very good. The number of medications is reasonable, 1 to 2 medications on average over the long term. The success rates were slightly lower than in all comers, I think, control patients treated without silicone oil. But the remaining patients that were not successful were treated with other adjunctive treatments like adjunctive cyclophotocoagulation or something that ultimately ended up controlling them. So we didn't really have any absolute failures in this series. One thing that is interesting about this group is that they all require long-term steroid use, any patient that has long-term silicone oil endotamponade has a certain degree of chronic inflammation. And so we found that on average patients need 2 years, up to 2 years of steroid use, topical steroid use, as opposed to the normal post-surgical patient in glaucoma that needs maybe 6 weeks. So it's a big difference. This makes sense if you reflect back upon use of silicone in other parts of medicine. They were removed, silicone was removed from the market for breast augmentation surgery because when there was leakage of the silicone, it caused chronic inflammation, and that's why it was removed from the market. So it does make sense that it causes this chronic inflammation, but there was very little documentation of this until this series was done. So at any rate, so just use long-term steroids. So drainage implants are effective. Implants are placed in the inferior quadrant. We use intraoperative viscoelastic so we don't lose the silicone oil intraoperatively. And then, they do require treatment for up to 2 years with steroids. And so that's a unique aspect of this group as well.
Okay. Can you switch? Okay, great. So we'll switch gears to cornea and glaucoma, changing concepts. As you all know, any patient with a penetrating keratoplasty, they have a 50%, 30 to 50% risk of developing glaucoma. The number one reason for somebody with a post-keratoplasty to go blind is undetected glaucoma. Cornea surgeons have a tendency to do cornea transplants, never check the pressure, or ignore the pressure even when they record the pressures are high with 1 or 2 drops. You cannot, because that's the leading cause for blindness in this group. 2, almost 30% of our patients following glaucoma drainage devices will develop corneal decomposition, which essentially means that you have to know how to handle a cornea pathology for both ways, because we are inducing corneal decomposition in some of these patients, and following penetrating keratoplasty, they're inducing glaucoma. So what better way than a glaucoma anterior segment surgeon to be comfortable with both cornea and glaucoma, right? So if you can manage both cornea and glaucoma all by yourself, I think your understanding of the pathophysiology is much better, and that's one of the things that I learned in my own lifetime. So cornea decomposition, like I said, is seen in 30% of patients. Glaucoma is frequently seen following PKP and DSECs. DSEC in GDD has 50% failure rate. We have a paper that's coming out pretty soon, and so think of new surgical options that are there. So why do these patients develop corneal decomposition when you use a glaucoma drainage device as opposed to trabeculectomy? We rarely see corneal decomposition when you do trabeculectomy, whereas when you put the tube in the eye, we do develop corneal decomposition. It's not from the mechanical component of it. I think all of us are now experts in this. We do the tubes in such a way that the tube is not touching the cornea. Even when you do it in the sulcus, far away from cornea, you still develop 30% incidence of corneal decomposition. And we proposed a theory of nutritional steal theory back in 2013 when we wrote the paper on DSEC and the failure rates, that it's because of nutritional deficiency the corneal endothelium is decompensating. Now, we had comments on that as to why and how, and is there any theory behind it. So we went back to our trusted rabbit model, and this paper actually got published in the RO TVST journal last month. So anyone who's interested can have a copy of that paper. So what we did was to take a bunch of rabbits, use the Ameth valve in one eye, and the other eye served as a control. And we looked at the oxygen concentration. We had this oxygen monitoring device from a company out in Cambridge. We borrowed it. They were kind enough to give it to us. And we showed conclusively that the right eye where the tube was placed, every single eye had significant hypoxia compared to the oxygen concentration in the unoperated eye. 2, they went on, and then we analyzed the aqueous samples that we collected before the surgery, at the time of the surgery, 1 month, 2 months, 3 months, and we followed these patients all the way, not patients, rabbits, all the way up to 6 months. We collected the aqueous samples on a monthly basis, and we subjected them to a new technique of analyzing the chemical content of the aqueous called Metabolomics. Now this uses a protein spike to study the concentration of some of the proteins. The older techniques that we used, the standard of care used to be HPLC to spike the amino acid content, and that's how we used to know that the the amino acid content is this much and this amino acid is high, etc. But it's not sensitive enough. This new technique of metabolomics that have been used in other parts of the body, this is one of the first studies that used it in this kind of a setup. And what we found is astounding. We found close to 300 components in the aqueous. And there were differences in almost 200 of them between the right eye, the operated eye, and the unoperated eye. We were able to identify only 68 of them with the known entities. We don't even know what these other 168 components that were identified that had a spike in the graph, but we don't know what those components are. And so there is a gross difference that is occurring in this aqueous chemical composition following glaucoma drainage device implantation. And we believe that one, hypoxia that is causing this, and two, nutritional change, the chemical composition change in the aqueous, a combination of both is the reason for corneal endothelial decomposition in these patients. Now, how do you explain this is based on this model. If you look at this, this is a schematic of what happens when you put the tube in the eye. Normally, aqueous, as it comes out from the ciliary processes, posterior chamber, is lying hugging on the iris. Iris is at least 1 to 2 degrees warmer than cornea. Remember that. So aqueous is warmer, closer to the iris, and cooler, closer to cornea. So that pressure, that temperature difference causes the aqueous to raise up to the cornea, bringing in the nutrition and the oxygen that's seeping from top down from IE cornea will give the nutrition and oxygen to the endothelium. Whereas once you put the tube in, this conduction current is disrupted, and you can study this in your own practice by injecting Kenalog in the anterior chamber after the tube is placed, and you can see clearly that the aqueous flow is identified flowing through these tubes, disrupting this pattern of current. And so we believe it is this change in the conduction current induced by a large bore tube that is the reason for hypoxia and nutritional deficiency causing corneal endothelial decomposition. So at the end of this paper that got published in TVST last month, what we suggested to the manufacturers is to reduce the diameter of the tubes. You make the diameter small enough, you're not going to lose efficacy, but maybe you will not disturb the conduction current, thereby decreasing the incidence of corneal decomposition. So cornea issues causing glaucoma, PKP, like I mentioned, 50% of all PKPs develop glaucoma eventually. K-Pro, all K-Pros or the keroprosthesis will develop glaucoma. So it's foolish for anyone to just do the K-Pro and think that everything is okay. It's not okay. Every one of these patients will go blind unless you pay attention to underlying glaucoma, because why? You're trashing the trabecular meshwork and the angle structures. So you have to put in some kind of a tube device in these kind of cases. More and more, to answer the question about mix in penetrating keratoplasty patients, any surgery that you do increases the risk of graft rejection. Two, you do a trabeculectomy operation on them. Almost 70% of the PKP patients need some kind of a contact lens for them to see better even after PKP, right? And so contact lens and a cystic bleb is a big no-no because of the risk of blebitis and endophthalmitis. So I am switching over to canaloplasty procedures and MIG procedures in penetrating keratoplasty with great success. And that's another paper that's in works in my practice. Angle surgery, like I'm showing here, is really changing the way I'm approaching a lot of these, using eye stents or using KDBs that I showed, and these patients are doing really well following this. It's something that I would love for glaucoma specialists in India to try and get a handle on, because we are seeing some good results. I'm not telling you that this is the end-all for all kinds of glaucoma, but definitely there is a role. The surgical results are better, and more importantly, they're very safe surgeries. So surgery is complicated by rapid air escape in DSEC when you have a tube in there. So a lot of times, DSEC, how many of you do DSECs in this audience? No one? So the way DSEC surgery works, as you know, is you don't do a penetrating keratoplasty. You strip the endothelium, you get the eye bank to cut thin tissue with the endothelium attached to it, or just the endothelium itself, and you float it in the anterior chamber, and you let it raise up to the surface by injection of air. So the air will lock it in place. After 24, 48 hours, capillary action will cause the desec button to be adherent to the corneal stroma, and after that, you don't need the air bubble anymore in the anterior chamber. Problem in the presence of glaucoma drainage device, the air bubble tends to escape out, and rapid escape of the air bubble through the tube will cause the desec to detach from the cornea, and so you may end up to refloat this a couple of times. And this refloating, I do it at the slit lamp. Here is a cornea with 3 tubes in there, okay? This guy had 2 traps outside before he came in, and it took 3 tubes and a partially working trap for him to maintain the pressure at reasonable levels. And eventually, 5 years later, a cornea decompensated. I did a DSAC. The DSAC, of course, the air bubble escaped out. And so here I am refloating the DSAC at the slit lamp. You don't need to take these patients back to the operating room. Here is a 30-gauge needle that I talked about attached to a Helon cannula, and you reposition the tube. What I do is the airlock technique. You tip the needle with viscoelastic, have air in between the viscoelastic itself, okay? And then you inject a little bit of viscoelastic, followed rapid injection of air bubble, followed by some more viscoelastic. That viscoelastic hopefully is going to block the tube entry for a little while, and the air bubble is locked in between in the viscoelastic bed itself, and giving you a better chance for the graft to be attached to the cornea. We have developed this technique several years ago. We've been using this for a long time. We wrote a paper on this. It works really well. And finally, these mini stents, such as the Zen that recently was introduced in the United States. I don't know any of you have exposure to it. The reason why I'm showing you this is the concept of having a tube with a big bore is really not needed. I think you can achieve the same thing with the smaller bore tubes, and that's example of that. It would be the Zen. And I'm anxious to repeat the studies that I did with the glaucoma drainage devices in rabbits to see if the conduction current and hypoxia is seen with smaller diameter tubes such as the Zen, which is what we're trying to show here. It comes preloaded on an injector. You make a 2 millimeter incision in the infratemporal quadrant, and you inject mitomycin to balloon the conjunctiva first, 0.1 to 0.2 milligram per cc concentration, and you enter anterior to the TM, just anterior TM or the border of the TM, and exit out through sclera approximately 2.5 millimeters posterior to the limbus. And as you watch this, you will see you can deploy the Zen pretty easily and come out. So you are actually not touching the conjunctiva or doing conjunctival dissection. All of the surgery is accomplished through a 2 millimeter infratemporal incision. We have to wait for the long-term results of this. Peter, you've been doing quite a few of the Zens? Yeah. I've been doing quite a few Zens. The success is pigmented patients. I'm not finding the Zen to be as successful as in white patients. So this is something that we need to watch out in terms of the results, post-op results. This is how it looks. That's the inner diameter of the Zen, okay? And this is how the Zen looks on ultrasound, and that's what the plunger looks like, the injector. Pretty easy and neat technique. It's extremely neat, the way the design of this device has been made. So that's my cornea glaucoma talk.
Yeah, just I have a question, not a well, I have a comment, then a question, then a comment. So the question is, so would you get the same result, do you think, with the lower O2 with any kind of transscleral filtration procedure, let's say trab versus tube or some? I mean, you looked at the tubes, but do you think it could be possible for other things? And also DSEC, could you comment on the rate of graft non-adherence with other types of transscleral filtration, trabs or whatever? I mean, is this something unique to tubes, or what do you think?
Yes, the answer to that is yes, and I do believe that the next generation of tubes that should come out into the market should have smaller diameter tubes with a plate attached. I don't think this Zen is going to work out in the long term. I'm seeing a lot of failures in my own practice. I have almost 60-70% African American population, and it's not working very well even in the short term. I have follow-up on 200 patients that I'm presenting in AGS in 2 weeks' time. In older Caucasian population, I'm finding good results with Zen.
Oh, I agree with that. I guess I didn't ask my question properly. On the sensor tube study, you know, where you have the lower O2 and stuff, is that unique to tubes, or you had the comparison of tube to control?
What's this trap?
Would that be possible with other types of transscleral filtration, like let's say TRAB or anything else, or is it unique to tubes?
Okay, so we have not done that study, but my guess is because we don't see corneal decomposition following traps, that pattern is not disturbed. Whereas when you have a big bore tube, pattern is disturbed, the circulation of the aqueous is disturbed, and that's why you see it. That's a study. I lost funding after I did this study, so I had to stop the second phase of the study. Hopefully at some point I'll do that study to answer that question properly in a rabbit model, but my gut and my guess is no.
But it might explain why we're seeing, you know, cataract is a complication of everything. I mean, of all surgeries. You know, maybe we're disrupting because the cornea issues are one thing, but we have almost a universal cataract problem after virtually any kind of glaucoma surgery. So it may have very broad implications for, you know, why that happens. Yeah, so it's great. It's great stuff. And a comment on the K-Pro. Dr. Ayala knows that I was. Keratoprosthesis is a really interesting topic, and I will comment that. So I did see up firsthand the situation with that, because Klaus Dolman, who finally retired, he did his last surgery I think at age 92 years old. I think he was 92 when he did his last case or something like that. 80, I think he was around 90 or 92. But when he first invented keratoprosthesis, he was a big believer that modulating the biological response was the key to success. So he wasn't a big believer in changing the materials to make them truly biocompatible. He just thought that we had to modulate the body's response to make it work. So he did groups of 50 patients to invent it. He did his first 50, and they all failed. 100% had scleral melts, and there were severe problems with the entire first series. But he persevered. He had a very persistent personality. And he did a second series, and he implanted 50 more, and he modulated the response, and 100% of those developed glaucoma. And we know that about 80%, 70 to 80% of people with severe ocular surface disease, I'm talking severe chemical burns and severe, you know, OCP or something like that, those patients have a very high rate of glaucoma. But if you added the keratoprosthesis to that group, it is approaching 100%. So I joined him after that series. He talked to me and asked me to join him, and I did the next 50 with him, and the next 50 after that. So I did several hundred keratoprostheses with Dolman as he was inventing it. And it was actually very fascinating to me, because we wrote the first paper about treating the glaucoma that came along with keratoprosthesis. So his second series failed. The third series, we treated the glaucoma. It had been unsuccessfully treated. Attempts had been made to treat it with cyclophotocoagulation, which were unsuccessful. So we did the tubes, and we published that in Ophthalmology with the next 50 eyes, and that was essentially near 100% successful. It was 81% pressure control, and the remainder of those were treated with medications and with to be successful. Lost a few patients, but very few. So ultimately, that's now standard of care, because if you have a keratoprosthesis patient, you absolutely have to treat the glaucoma, because it's essentially 100%. And I did happen to experience that firsthand. It was an interesting story, you know, interesting to experience it, and it was it left a strong impression on me when I observed it firsthand, but it was an interesting story. You had a comment?
No, I was just going to say that I was a fellow with Peter at that point in time when Dolman realized that he had to use valves. Actually, the Ahmed valve was just introduced. I remember one evening, 1 month after I joined as a fellow in Mass Eye here, Martin Ahmed walked in, and at 6 o'clock in the evening, we had a session where he explained the mechanics behind the valve, and they started using the Ahmed valve, and that's how I mean, it was a great experience.
Yeah, early 1990s, and then that's when Dolman was struggling with his keratoprosthesis. So it was a fascinating time, actually. And now, of course, 30 years later, we see the consequences. But now the rate of keratoprosthesis is increasing dramatically, and it's now becoming more acceptable for care. Trabeculectomy. I'm not going to really comment on this very much because we've talked about it. I'm actually going to, so we're going to finish ahead of time so we can have a long, good discussion. So I'm going to cut this really short. I'm going to skip ahead, actually. Yeah, I mean, it's not a perfect procedure, but it's good. And so how can we increase the success? First of all, case selection is very important. So if you know that there are certain patient characteristics that can lead to poor success or certain types of glaucomas, then you can improve your success with trabeculectomy by avoiding patients that have a high risk for failure from trabeculectomy. These are the different types of glaucomas that are known to have a poor prognosis for success with trabeculectomy. And we talked about it earlier. In certain situations, if it's well controlled neovascular uveitic, can all have good results with trabeculectomy. But there are some patients that don't, and so it's considered to be a poor risk group. We used to do incisions within quadrants. Now we're doing more superior incisions just because we do a drainage implant a lot of times, and we don't need to do it in a quadrant. I'm not going to do this. So prevention of fibrosis is helpful. Mitomycin C has been helpful to improve the success rate, so it does help to use anti-fibrosis drugs. It does have some long-term complications, but the success rate is improved markedly, and so now it's sort of a standard of care. And a final comment I'll make, I'm not advocating for the express implant, but I will say that if you can continue to, modifications of trabeculectomy have led to increasing success rates over time. And this was a thing that became popular with surgeons, and it was mainly because of decreased complications. And we finally looked at this with a prospective randomized clinical trial and found that, in fact, the success rates were very similar. So you don't have to add that to get better success. And in fact, in India, we were talking about it earlier, you'll be unlikely to convince many patients to purchase this. But if let's say in a fantasy world, if cost didn't matter, zero worry about cost, would you do something if it's better? Maybe you would. Well, this was better because it reduced complications. That was the simple answer. So that's why surgeons liked it, but cost issues are relevant, and so they use it less frequently because it costs money. But the main result of that study was to find out that it did reduce complications very significantly. So complications are important because you can improve your success by trying to minimize your complications. And the number of ways to do that, we've all found that if we try to minimize postoperative hypotony using laser suture lysis and other techniques, we can really have a tremendously positive influence on complication rates, reduce post-op hypotony. If we use mitomycin C, judiciously, as we talked about earlier, you can avoid complications with that. And then all these other complications are things that we can manage as well. There's many problem blebs. All of these things can be managed with a variety of techniques. If you ultimately have complete failure of the trabeculectomy where the conjunctiva is not mobile over the sclera, it's adherent to the episcleral tissue, you'll find it very difficult to get that bleb to work. And then you sometimes have to move on to another procedure. But you can do many things to improve the success rate of the current procedure by becoming facile with treating various kinds of problem blebs. So prevention is the best problem. Avoid the inferior trabeculectomies. Those are known to be associated with a higher infection rate and higher problems. Avoid hypotony. Control blepharitis and other things that may be risk factors for problems. And appropriate patient selection is very important. So modified trabeculectomy is a gold standard, using laser suture lysis, anti-fibrosis drugs. Trabeculectomy does continue to evolve and improve. It has from the beginning of when it was described in the 1960s. We don't do the same procedures we did in 1960, right? I mean, it's continued to evolve and improve, and it's really quite good now. But it can be improved more, right? Anytime you have any complications, you can try to reduce them more. So they'll continue to improve. And one of the ways that it's improving, continuing to improve, is by trying to minimize complications. So that's all the comment I wanted to make about that. Any comments or thoughts, and then we can all discuss that. But I'm trying to shorten that because I know we've talked about that a bit earlier today. Any thoughts?
Why don't you go ahead and wrap up the session with a
Migs.
5-minute conversation on MIGS.
Yeah,
Sorry.
please. Yeah. Yeah, please do.
But yet I would say something, but I think what was said was that, we are going to get cataracts. I think that's another myth. Please, there is no reason for a trab to develop a cataract or accelerate a cataractogenesis unless you have a shallow anterior chamber. So I think most of the so-called progression is because of age-related sort of changes in the lens that are occurring. But to actually say that, there's a significant decrease in vision, as we were all taught in our textbooks that, once you do a trab, 2/3 of them will show you a drop in more than 2 lines and you are going to get a cataract. Those are things we don't see anymore. I think if you keep your releasable sutures or tight sutures and laser suturolysis and things, this is not something that we see. It's only seen now with patients who develop a shallow AC hypotony and things such as those in the early post-op period. Utho. We do not do is we don't put Invisalign or Helon, because obviously this is not going to stick. The second thing is that many of our cases where previously an Emmet glaucoma valve has been implanted, we have found that if we do not remove the tube, then that tube goes and touches the graft and that causes failure. So this has been our experience, that we don't need to remove the entire thing, but we definitely need to remove the tube when we are doing a DSEC. And it is, as for the express shunts, shunts are, the amount of pressure decrease is not all that good. And even implantation, during implantation, there are many problems. Oftentimes the shunt just doesn't come out, even when you're doing it in the best possible manner. And I have one patient whose shunt is just hanging like that, and I fear the day when the shunt will fall. And so these are my comments on, because all these procedures which you have talked about, most of us are doing it, and we find that they are slightly at variance with what you are talking about, sir.
In what way? Specifically the shunt or the...
So the DSEC, that definitely, sir, we don't put in Helon.
Okay.
In fact, if we put in Helon, we would prefer first of all to do a good trab, control the intraocular pressure,
yeah,
and then go ahead and do it. Then do the DSEC. And if when we are doing the DSEC, in that case, in case there has been, let's say for example, we have done a cataract surgery and then we are putting in, we are doing the DSEC, then in that case we'd prefer to remove every bit of Helon that we have injected and then allow the graft to stick with air. So that is how we do it, and we find the results are good. There was one case where the tube, for whatever reason, was not removed and we had failure.
Yeah, I'm specifically asking, I can't comment on the DSEC, I'm sure your comments are accurate, but are you talking about the express shunt?
No, that is a different thing. We also do express shunts.
No, I'm just curious as to, so you're saying, so you're not commenting on the part...
So there are 2 parts which I've commented upon. One is about the DSEC and the
main
Helon,
yeah, okay, so the main comment is on the DSEC,
and second
I can't
is
answer
regarding the express shunts.
Express shunt, I can tell you, I can comment on that. I do have a lot of experience with that, and lots of many cases. So, and I've seen a lot of the adverse effects. I'm not sure exactly what you're describing as far as the shunt being dislocated in towards the eye. That's pretty rare, but I will comment that it's. I'm sorry, you were saying? Yeah, so those kind of things can happen. The point that I was making is in the larger studies, in terms of what it adds. What it adds is it's the same exact efficacy as a trabeculectomy. There's no advantage in terms of mean intraocular pressure or number of medications. It's the same exact result with that. There are some unique device-related complications, but those have been in papers now have been studied, not just our series, but many. They're a pretty small percent. It's less than 2% of device-related complications. So, I mean, you might have an occasional device that's dislocated or something, but I don't think it's a routine thing, or at least it shouldn't be. I'm talking about the large series that have been done. It's a small percentage of device-related complications. But I will say that the main advantage of it, just trying to emphasize that as the evolution of things, if you're looking at what is the Express implant, why was it attractive to surgeons? For a lot of reasons, but the main reason was because it further reduced the complications. That's the only thing you can prove in a randomized prospective clinical trial. So the efficacy is the same. So if you want to just do a procedure to get at a certain pressure, mean pressure of 12, and have a certain number of medications, you can just do trabeculectomy. You don't have to do an Express. But if you want to try to further reduce complications, it does help in that regard. Again, I think you're describing a few anecdotal cases. I can only comment on the big series. I've been involved in several big series. I've been involved in a lot of other things. I can tell you that the number of device-related complications is pretty small. In terms of removing them, it's quite easy to do. You have to, use a 15-degree super blade. It's got a hook on it, so you just have to put the blade to that and then just pull it out. So it's not difficult to do if you need to, remove it. But those are pretty small percentage things. Now, again, maybe there's a higher risk group here. So I can comment on the Express, but I can't comment on. I was just using an illustration of how the evolution of things. What was that doing? It's basically was to reduce complications. The main vision-threatening complications, which are, hypotony and choroidal, suprachoroidal hemorrhages and things like that. So, in prospective studies.
I think I published the first series, a case series of complications on Express.
Yeah.
And I can tell you, almost all of them were performed by people who didn't know how to do the surgery.
Well, they were putting it under the conch without
under
a flap.
Conch. Initially, they were putting it under the conch, not under the scleral flap, and that resulted in exposures, endophthalmitis, suprachoroidal hemorrhage, etc. Once we published that, they changed it into more like a trab-like a facility.
It's a modification of trab.
Modified trab. And over the years, I've seen everything that you said. Okay? And a lot of them are because those Express shunts were not placed properly, in my experience at least. I'm not saying anything about, I've seen this referred in patients to me, and I've seen exactly what you're talking about. And I can tell you 100% of the time, it's improper surgical technique that resulted in them. Now, Express will fail, just like trabs will fail. No surgeon can stand up and say, my trabs are 100% successful. It's not possible. The same thing with Express too, and I think that's what Dr. Netland is pointing out. But those things going into cornea, the device was never designed to go into cornea. These surgeons, in their anxiety, whatever it is, the improper technique is what led them to place it into cornea, or the dissection of the scleral flap itself left such a thin bed that the plate of it is eroded into the anterior chamber, and it looks like it's hanging in midair. Now that's about Express. Coming back to D-sex, a lot of these patients with tubes in the eye, they all had failed traps. These are all complex cases where traps did not work to begin with. Conjunctiva is completely plastered in. That's when they all went in to have tubes. After that, what do you do if they develop corneal decomposition? A lot of surgeons, cornea surgeons especially, suggest that we tie the tube down or we take the tube out. You're adding another step to a surgery, and post-DSEC, you're going to have the same problem with the intraocular pressure control, right? Elevated intraocular pressure is a definite risk factor for that graft to fail also, plus the damage that's done to the optic nerve. What I found, I have done close to 200 to 300 DSECs in the presence of tubes. We have probably the longest follow-up on DSECs in the presence of tubes. The second paper with one tube versus two tubes in the presence of DSEC is getting ready to be submitted for publication as we speak. What I found is this. Yes, the failure rate is high, as is with any cornea situation in the presence of tubes. But you don't need to take the tube out for the graft to be attached to the plate. If the graft is getting stuck in the tube, or that means that the tube is not properly positioned to begin with. I mentioned that in the very beginning itself, that when you place the tube, you got to make sure that it's nowhere near the graft, nowhere near cornea to begin with. There's no situation where the tube is so close to the corneal endothelium that you want to do a DSEC, not replacing the tube. Those cases should have been addressed before the cornea completely decompensated during the follow-up. I always watch if the tube is migrating or the tube is touching the cornea. I don't even wait for the cornea to start decompensating. Why? Because we're in the business of preventing disease process. We do know you follow that path, cornea will eventually decompensate, so I take the patient back in and put the tube in. Now, if there is a properly positioned tube and there is corneal edema and I have to do DSAC, I feel that you can accomplish that very well without taking the tube out and doing two other additional steps here just by using viscoelastic in the AC, a bed of viscoelastic, suspending the air bubble between the viscoelastic on the top and the bottom, plastering the DSAC, and that gives you enough pressure for the first 24, 48 hours. And I have many, many, many patients that have done like this. And that's the only reason why, like I said, all of this, whatever I'm talking, whatever he's talking, is based on our clinical experience in our practices. There's nothing that I'm saying that I read and I'm saying to you. I practice what I'm saying.
And let me ask the question the way I heard it. I may have gotten this wrong, but you're saying specifically the viscoelastic, right? Is that so? What she's saying is, I think, do you do regular DSECs without viscoelastic? And
yeah, regular DSECs I don't use viscoelastic.
Okay, and so
you're absolutely right.
And so do you need to use that for the tube thing?
For the tube, you do need to, simply because the air will escape out real fast within the first few hours, and then there's no pressure in the chamber for the DSEC to get attached. So in those situations, now I do know some cornea people in my area who tie the tube down, additional step, and then they like to open the tube later on, and in the immediate post-op period when the pressure goes up too high, they refer the patient to me and wash their hands off. These things happen all the time. I mean, I see it in the area that I practice in. We have a lot of people who practice in the community, and they attempt to take care of these complex cases. And when it comes to tubes, I find the technique that I use, this airlock technique that I developed, works very well in my hands at least. And it avoids taking the tube out.
Fortunately, I'm not a cornea person, so I can't comment on that at all. I'm sorry. So I don't know.
I think we're out of time now, right?
We have another, I was going to show my thing I can show a very truncated version. We have another 10 minutes, I think, but
okay. We'll
try to open it up I'll do 5 minutes on this, and then,
sure.
And then open it up for discussion, and we can finish with a few comments. We were talking about this earlier, but I think, I'm just going to try to give a sense of where things are going with, glaucoma treatment in the future with the MIGS. I would just comment that, the next generation, certainly of all the fellows that I see, they're anticipating now that this is going to be their future. They're not going to be doing any of the things we do now. I think that's generally true of most of medicine, that the things that we're doing now, 20 years from now, we won't be doing any of it. And of all the glaucoma fellows that I see and I work with, they all are having an expectation that this is the direction that it's all going. And I would have to agree with them. We're going in this direction. We didn't show the numbers for this, but these are rapidly taking over in the United States. I'm not going to go to too much detail because, some of the procedures are not available here. The only things I'm going to talk about are FDA approved in the United States, and they're currently being used in the United States. Where it goes here, I'm not sure, but I can tell you that it will come. So patients and surgeons are both seeking a procedure that's safer, more effective and predictable, and we have a lot of advances in primary surgery of glaucoma. In fact, this is one of the most active areas of development in ophthalmology at this time. So early treatment is desirable. Procedures that are safer may have a role, and so we're talking about minimally invasive glaucoma surgeries. And what I'll do is I'll just mention a few of these, the ones that I commonly use all the time, and But I'm not going to dwell on the technical aspects because some of these things aren't available in your practice. Some of them will change, next year. These are all approved and used in the United States actively right now, though. Trabectome is a electrosurgical tip. It's like doing a goniotomy, but you remove all the tissue. It produces mean pressures in the mid-teens, mid to low teens, and on average on one medication. Trabectome has main complication is hyphema because you get reflux of blood from Schlemm's canal. It's always essentially transient, and it has no adverse effects that anybody can tell at this time. So clinically, we use it for mild to moderate glaucoma. We use it a lot for combined surgery, and it's been quite excellent for that. Cook dual blade is a KDB is a very similar procedure. It essentially removes the Schlemm's canal. It removes the trabecular meshwork using a goniotomy-like procedure, but it has two blades, so it actually excises the trabecular meshwork instead of making a slit in it. So it's a sort of goniectomy, you might say. And this is the way the procedure looks. I'll just get to that point a little bit, then we'll move on. But you essentially just pass the KDB across the anterior chamber and then treat about 90 to 110 degrees, removing the trabecular meshwork. So this is done in a direct visualization. So that's sort of what it looks like. And it's rapid and easy to perform and can lead to good pressure control in many patients. This is the eye stent. We don't use this much anymore because it has a more variable response in my personal experience. But it's used by a lot of cataract surgeons. So I won't go into that too much. Canaloplasty, I don't do. Dr. Ayala does more of this, but you can use a device to cannulate the Schlemm's canal, and then place a suture in there and do what's called a canaloplasty. To me, it involves a little more time, and now I think that some of the procedures are producing a similar result without having to spend so much time doing the dissection. Aquasys is the Zen, and this is becoming popular, and it does lead to a transscleral filtration through a MIGS approach, and it's sort of like a trabeculectomy, but minimally invasive, and it takes a very short amount of time to do this. The CyPass is a suprachoroidal space device. This has been an evolution over the last 10, 15 years. There was a non-MIG procedure, the Solex Gold Shunt, which was approved in Europe and in Canada, never approved in the United States. But this has been approved in the United States. It's actually easier to do, equally effective as the Solex Gold Shunt, and produces drainage into the suprachoroidal space. So all these procedures right now are limited because the pressures they produce compared to trabeculectomy are in the mid to high teens on average, on all the series that have been done for most of them. On average, many of them do require one adjunctive medication. But all these things are in evolution, right? So when trabeculectomy first came out, as it was initially described, I looked it up, I went back through all the original papers. The average pressures were in the mid-teens. Average of one medication. It's the same exact thing. So these will continue to improve over time. Surgeons that I talk to every day are thinking of ways to make them more and more effective. And so we will see these pressures come down, and these kinds of minimally invasive approaches, I can assure you, because the next generation, they're not interested in, they're interested in doing these. So they're going to modify it and continue to improve it. So in the immediate future, we're going to see incremental improvements in the mean postoperative intraocular pressure, so it will compete with trabeculectomy. It'll be averages in the low teens. We'll see improvements in success rates. We'll see further reductions of complications. Already they're pretty minimal, but we'll see further reductions, and we'll see continued replacement of trabeculectomy. Long term, we'll see elimination of competing procedures. Right now we have several different things. We have suprachoroidal drainage, we have transscleral drainage, and we have improvement of conventional outflow by doing procedures that work on the anterior chamber angle. We don't need all those procedures. In 20 years, we'll have one. We'll have, just like trabeculectomy, we'll have a continued simplification and, elimination of other procedures. And the long-term future, I think we're going to see procedures that normalize outflow and bypass outflow that will survive. So the ones that are supposedly MIGs that improve, that reduce inflow are probably going to go away first. But in the long term, we'll see the procedures that normalize outflow, again, to normalize the problem that's causing the glaucoma in the first place, the high pressures. So those are the trends, and I think, I just wanted to make a few comments to say that the trend is that this is, definitely not going away. It's going to be continuing to stay and continue to develop. Do we have any residents here now, or any fellows, glaucoma fellows? Well, if I were to poll a group of residents and glaucoma fellows in the United States, they're going in this direction. They're not satisfied with the current procedures that we have. So I think it's going to continue to develop and get more established. And the future, I think, is going to be, in this area. So that's the way I see it now. Any comments?
I made my comments on MIGS before. Initially, the MIGS was relegated to mild glaucomas. In my practice, what I'm doing is to combine MIGS, one or two techniques. It's just like our glaucoma drops, okay? One glaucoma drop increases outflow, the other glaucoma drop decreases the production of aqueous. Why not do the same thing in patients when you're going in for cataract surgery anyway? A patient is having cataract surgery based on the intraocular pressure reduction that is needed. You titrate and do one mix that will increase the outflow pathway, add another mix to decrease the aqueous production. The combination is you have avoided doing a trap, at the same time achieve the target pressure. Two, doing mix, a combination of these techniques that Dr. Nicklin just showed in patients with failed traps. For example, patients comes in with a trap or a tube that's not functioning or partially functioning, and the patient is back on 2 or 3 drops. These drops are expensive. You want to go in to do a cataract surgery, you might as well take advantage of the situation that you're inside the eye. These are so safe. One thing about MIGS, they're extremely safe. We have not seen complications with MIGS, and that's a true statement. I mean, in your practice too, Peter?
That's one of the main drivers for this.
Yeah, I mean, compared to any other glaucoma surgery, this is the safety of MIGS is as good as doing a cataract surgery. Can you have endophthalmitis? Yes, of course, but barring that, there is no other risk that is associated.
Visual recovery is great. That's why the glaucoma fellows, that I train, that's why they don't want to do other procedures. They have their first MIG. The patient sees well the next day, and within 2 or 3 days, they see their normal vision. They don't want to do another type of procedure. So that's going to be the driver. The other thing we were talking about, cost. If you compare the cost of this, doing one procedure like this, to the cost of other alternative therapies, they don't compete. So we're going to have a lot of drivers for this in many different ways. When they were developing these, they were not going for just competing against other surgeries. They're going for competing against drops. So if you compare this to giving drops, not for us as doctors, but for a society, a government, usually these procedures win over drops for cost. So if you have that kind of driver for it, so I don't know. I mean, I'm not advocating it or saying, we shouldn't do it. I'm just saying there's some very powerful drivers for this, and they're not going to go away. So, we're going to see this for a number of years to come. It's not just a transient thing.
Any questions? Yes, sir.
Regarding the risk of infection after the trabeculectomy, which you mentioned, my observation, just tell me whether it is correct or wrong. Like over the years, I've done so many trabeculectomy surgeries, and in my hands, I've seen that the blebs. We can know which sort of blebs are going to be risk-free of any infection. We can safely go for apnation tonometry, and we don't have to tell the patient that there is a risk of. But there are some blebs which are thin blebs in which cystic changes, and those sort of blebs we have to always be worried about. Like they can develop. I don't use releasable sutures, but my technique with 3 sutures one in the apex and the two in the sides. And with mitomycin C I use in every patient, and they tend to be quite fine. And with massaging technique, postoperatively, it works quite well.
No, I agree. First of all, I don't think the blood morphology has anything to do with your surgical technique. Let me tell you this. You can do any which way you want. The blood develops its own mind. Some of them will scar down, some of them will function perfectly well, and some of them will become huge and avascular, and it develops its own mind. It has nothing to do with your surgical technique. The patient's morphology is what is going to decide the shape of the blood in the long term. Number two, cystic avascular blebs are at a higher risk of developing this. There's no question about it. So what do I do? Every single time I see these patients, I look at the blood, I look for leaks. If there is a cystic blood that's leaking, I don't wait for them to present to me with infection. I tell the patient, I take the patient back to the operating room. I use a technique that I published upon, amniotic membrane cover the cystic blood, and then drape it with conjunctiva on top of it. I get excellent results with it. That's what I do. I reform the roof of the blood, so to say, to create a healthier looking blood to prevent endophthalmitis in these patients. I think it's foolish for us to wait when the patient presents to you with a glaring leak in a avascular cystic blood for you to wait it out to present with endophthalmitis, right?
Just one more observation. Like a few weeks back, I operated on a patient who is a one-eyed patient. And his vision was around 6'9", 6'12". And I attributed that to the cataract formation, the nuclear sclerosis. And then I went for the trabeculectomy surgery. And within 2 weeks' time, suddenly one day he was telling me that, I'm not seeing well. My vision has dropped. And when I examined the patient, I saw that he was recording -4 diopter spherical refraction, and which has increased to -7. So I was attributing whether it is because of the nuclear sclerosis increasing after the trabeculectomy surgery, leading to this change in refractive status, or whether it is a change in the position of the lens, which is attributing to the increased myopia. So what is your observation?
In my experience with myopia, when you make the cut, the same trabeculectomy incision that you make in a myopic eye versus a hyperopic eye versus an emmetropic eye, you're more likely to induce astigmatism, higher astigmatism in a myopic eye compared to a normal eye or a hyperopic eye, number one. So I have measured personally in my own hands the exact same surgery that I do in every single eye. In a myopic eye, thin sclera, I've seen some astigmatism as high as 6-8 diopters in the immediate post-op period, gradually gets better over a period of 3 months. Okay, and it comes back to whatever it is, like half a diopter or so, which is what the standard in most other eyes are. In your situation, it's unlikely that the lens has moved because you don't go anywhere near the lens when you do a trabeculectomy. So I have to believe that somehow the nuclear sclerosis has changed in a dramatic fashion. And occasionally you see that the cataract formation becomes more rapid and more accelerated occasionally in this kind of situations. So I think it brings back the question that Peter was asking, changing the aqueous dynamics is the leading cause for long-term or earlier cataract formation in following trabeculectomy or any of these glaucoma drainage, any of these glaucoma surgeries, generally speaking, as opposed to other kinds of surgery. So,
yeah, getting back to the earlier comments that were made, so whether or not you see a clinically significant change in the cataract, after regular, any kind of glaucoma surgery, anything. Even glaucoma medications, I don't know, you'll have a small percentage that will have a pretty significant shift. But I would like to comment that overall, if you look at every clinical trial that's ever been done on this, where it's measured cataract carefully, you'll see a change in the cataracts with everything you do, medicine, any kind of surgical treatment. So my comment earlier was that, it generally is associated with cataract progression. So is everything you do, medicines, everything. They've all been measured to have some effect on the lens. Now, whether it's clinically significant if they drop 2 or 3 lines is a different story. Now, that's a very interesting case where you have a big myopic shift. Let me ask you a real quick question. Was that a hyperopic patient initially or an emmetropic or a myopic?
No.
Emmetropia. Just regular patient. Okay. Because you can have a pretty significant shift in the lens position during the relatively early postoperative period in some patients. I mean, I've seen it more with hyperopic patients, but you can see it in different patients. And that can cause it. But I would back up. I think it seems like it's really fast, but I would say it's probably the lens itself too, unless you've seen some obvious shift in the shallowing of the AC. If you see a big shallowing of the AC, it can be the lens position. Obviously more common.
Otherwise, AC appeared quite normal.
And probably it is the nuclear sclerosis, and that is really interesting. It's we were talking about that earlier, but it's not common to see that now. But you will see if you measure the lens, you'll see a small change in anything you do. But to see big clinically significant changes isn't common. But most likely it's the lens itself. It's a tough case, but interesting case.
Thank you all. We'll wrap up the session. Thank you for staying so late in the evening, especially to listen to a glaucoma talk. So hopefully we all shared some interesting pearls, and we learned some along the way. Thank you, Dr. Netlin, for coming and taking the time.